Welcome to MS NEURO TV. Welcome back if this is not your first time with us. Tonight we will be covering the complex topic of the immunology of MS, or as Dr. Boster likes to call it, T-cell university. We're going to be covering this topic tonight. There's a lot to learn and a lot to understand about the immunology of MS. Before we get started, I'd like to just explain to you again, we'll be playing about a 15-minute video with Dr. Aaron Boster. Once the video interview has finished, we'll have Dr. Boster on the line, and he will be able to answer your questions live. So please write down those questions and answers. Once that's over, you will receive a brief survey. We would love for you to complete that survey. We value your opinion and we want to know your experience. We love to read your feedback, and we craft these programs for you. And so whatever you share with us, we value and we take into consideration for our next programs. Before we play this video, we'd also like to recognize our supporters and sponsors for the support that they give us for educational programs for the multiple sclerosis community. We'd like to thank Celgene, Sanofi-Genzyme, and Biogen for their support this evening, and for supporters like you on the line tonight. Thank you. Without all of your assistance, this would not be possible. So thank you very much. Also here tonight with Bill Shanley, our production producer. Hi, Bill. Are you there?
Yes. Hey, how you doing?
Great. How are you tonight?
I'm doing good. Looking forward to this webinar.
Great, thank you, and thanks for producing such a great webinar for us. So I guess we're going to get started. We'll start the video, and we'll be back on the line. Please know that if you are only listening through the phone and do not have computer access, you will hear a period, a 15-minute period of silence. We are still here, but just hang on the line, and then you'll hear us come back after that video is over, so you can hear the question and answer portion. All right, so let's get started. Thanks, Bill.
Welcome to MS NEURO TV, presented by MS Views and News. MS NEURO TV is a comprehensive educational program bringing together MS professionals from across the United States covering the topics that you want to learn more about. To register for MS NEURO TV webinars, visit www.msviewsandnews.org. Thank you. We hope you enjoy the program.
Dr. Boster, could you please explain multiple sclerosis, MS, and tell us about the disease path with and without one of the disease-modifying therapies?
To understand MS, we first have to consider the immune system. So the immune system are the soldiers that fight off bad guys in your body. They're made up of a bunch of little white blood cells, and they're born in the bone marrow. Now they leave the bone marrow and they go to school up in the thymus, and that's called T-cell university. Now T-cell university is a very weird school. First of all, it's free to get in, everyone can go, and there's only one class. Can you identify self versus non-self? So if I show you a foreign invader, or if I show you one of your own cells, can you tell the difference? In all the white blood cells that graduate from T-cell university, there's only one profession. They become soldiers. Literally, they're soldiers. They're given weapons, and they tool around the human body looking for foreign invaders. And when they see one, they identify it as such, they take a picture of it, they call their friends over, and then they stomp it to death. And that's how you clear an infection. But let's go back to T-cell university. what happens if at T Cell University, the white blood cell can't tell the difference? He's murdered. So it's a weird school because they kill you if you fail the class. And so only the cells that are able to differentiate self from non-self are allowed to propagate. And so as such, you shouldn't have any friendly fire. You shouldn't attack yourself. Now, autoimmunity is a term that we use when the immune system has made an error in judgment. And it's by accident identified part of our self as a foreign invader. Every once in a while, a cell goes to T Cell University and it fails the class and it's not murdered. And that cell graduates with the rest of his fellows, and he is a soldier and he tools around the human body. But when he sees a self cell, he thinks he's looking at a foreign invader and he attacks it as such. Now, if that autoimmune attack occurs in the joint, we call that rheumatoid arthritis. And if that attack occurs in the pancreas, we call that type 1 diabetes. Multiple sclerosis is an autoimmune condition where the immune system attacks the brain, the holiest of holies, the supercomputer that runs our body, and the spinal cord, the superhighway that takes all that information from the head down to the toes and back up. Now, multiple sclerosis typically manifests around age 30 and is characterized by attacks or relapses or flares or exacerbations. That's all the same thing. It's when the immune cell leaves the bloodstream, crosses the blood-brain barrier, and identifies a part of the brain and attacks it. And where the attack occurs determines what kind of symptoms the human being experiences. If that inflammation, if that inflammatory autoimmune attack occurs in the nerve that runs the eye, you go blind. And if that attack occurs in the spinal cord, in an area that controls the down theres, your bowel and bladder don't work. And attacks typically present over hours to days, and then they can last for weeks to months, and then they'll get better. They may get all the way better, they may get partially better. And oftentimes people with MS don't fully recover from an attack, and they're left with a residual deficit. So if I use the example of the eye, they lose vision in their eye because of an autoimmune optic neuritis, and they only get half of it back, and now the person's legally blind. In addition to attacks, people with MS can suffer from progression. And progression is worsening. Their exam worsens in the absence from attacks. And both things are present in most MS patients in various degrees. Now, in the modern era, 2018, we don't do the natural history of MS. MS natural history is a doctor's way of saying, if I don't treat you, what do I expect to have happen? And to be very blunt, I don't want to share with you what that story is like, because it's a story of loss of function. It's a story of using a cane and a walker in a wheelchair. It's a story of having increasing difficulty with thinking and memory and profound fatigue and loss of work. In the modern era, 2018, I don't do that. No MSologist allows that to happen. The early application of MS therapies, disease-modifying therapies, can change this disease. And with our patients, we don't want them to experience the natural history. We want to make them the most awesome version of themselves despite having MS. And if we play our cards right, we can make MS kind of boring. I think of another autoimmune disease, diabetes. And diabetes used to kill people. People would die from diabetes. Now, you might not even know your buddy has diabetes unless you happen to eat chocolate cake with him and he gives himself an insulin injection. You say, hey, what's that? Say, oh, that's my insulin. If we play our cards right, we can make MS boring. It requires a tremendous amount of work with the person living with MS. It requires taking a disease-modifying therapy. It requires staying physically active and exercising as part of their lifestyle. It requires them to avoid tobacco smoke, which speeds up their disease, and it requires them to supplement low levels of vitamin D. But if we play our cards right, we expect people with MS to live a normal life expectancy and a normal life quality on therapy.
Dr. Boster, also, can you please tell us how MS is diagnosed? Can you also tell us about MS relapse?
Diagnosing MS is not straightforward. There's no easy blood test where you can get a lab back and say, it's positive. We have a set of criteria which are very solid, and we can apply these criteria to an individual and with great certainty identify whether or not they have MS. And so let me break down for you how we do that. The disease is typically defined, the relapsing form of MS, by attacks. And so the first order of business is to take a clinical history, to listen to the human being, describe their experience. And what we're listening for are discrete episodes of neurological dysfunction. An example would be an optic neuritis and loss of vision in your eye. And we're looking for a description that is classic for optic neuritis and wouldn't be suggestive of another process like a vascular thing. And then at a separate point in time, we'll have a second discrete episode of something bad happening, like a leg that goes completely numb, suggestive of like a spinal cord injury. And we look for what we say dissemination in space, which means they occurred in different parts of the nervous system, affecting different parts of the body, and dissemination in time, meaning those two things didn't occur at the same moment, they occurred separated in space. And so you want to try to flush that out with the clinical history. The second order of business is to do a neurological examination. And so this is where the neurologist has you touch his finger and has you track and do things like this. And what he or she is doing is he's looking for evidence on examination that supports the history. So for example, if the person tells me, hey, 5 years ago I lost vision in my right eye and then it came back halfway, there are certain things on neurological examination that I expect to see which supports what he's telling me. And so we want the physical exam to buttress what the history tells us. The third element, which has become increasingly more important in the modern era, is the utilization of the MRI. And so part of the diagnostic process is to obtain an MRI of the brain and oftentimes an MRI of the spinal cord. And on this MRI, we're looking for lesions or spots. These are these white spots that we see. And we're looking for these white spots in certain specific locations in the brain and spinal cord. Now, if you have a history which matches up and physical exam findings that support it, and an MRI that supports MS, using the current criteria, we can diagnose multiple sclerosis. Sometimes they don't all match up, and sometimes we need to do second MRIs or third MRIs, 6 months or a year apart, to look for the evolution of spots over time. Or we may end up waiting for the person to have a second attack and then make the diagnosis. But we try as hard as we can to condense it down and to make the diagnosis more quickly. Now, the fourth element is a lumbar puncture. And a spinal tap is not required for diagnosis, but if there are, it's called unpaired oligoclonal bands, that's a mouthful. If there's abnormal findings on the spinal tap, that can hasten the diagnosis quite significantly and allow us to make the diagnosis much faster. The fifth element that we have to consider is proving it's nothing else. And that's a very important task. So if you lose vision in your eye, there's a lot of different reasons you can lose vision. It could be a stroke, it could be diabetes, it could be an infection. And so we have to make sure as we look for the proper history in the physical exam and the MRI findings and maybe the spinal fluid, that we also do diligence and rule out other items. And so using these criteria, we're able to clarify that we think an individual has relapsing form of MS. Now there's another kind of MS, progressive multiple sclerosis, and there's a criteria for that also. It involves different historical elements because people with progressive MS almost never have attacks. What they will have is a slow, steady, insidious decline in function over a couple years. And we're looking for a different history. We still use the exam in the same way, and we still use the MRI largely in the same way. And spinal fluid can be helpful as well. But the progressive MS is going to present differently, and we have to be sensitized to that to make a proper diagnosis. A question about what is a relapse. A relapse, a flare, an exacerbation, these are all the same thing. I like to call them attacks. And it's when the naughty autoreactive immune cell leaves the bloodstream, crosses the blood-brain barrier, and identifies part of the central nervous system, brain or spinal cord or optic nerves, as a foreign invader, and it attacks it. And it attacks using inflammation. It causes swelling, it brings in cells and water, and it causes dysfunction in that area of the brain or spinal cord. And that correlates with some type of symptom clinically. And so I'll again use the optic nerve. You only have one nerve that goes from your right eye back to your brain, and it's really thin. And if there's inflammation there, then it short circuits, and you can't see light, and you go blind. And that is an attack. Now, attacks occur in a subacute fashion. Subacute means that they don't happen suddenly, like a stroke, and it means that they don't happen slowly over months, like you might see with a tumor or cancer. They typically occur and manifest over hours to days. The manifestations of an attack, the blindness in an optic neuritis, typically lasts days to weeks, sometimes months, but not normally, and then they can recover. And recovery from an attack is variable. Typically earlier on in the disease process, we tend to see a more complete recovery. Later in the disease process, we may see less of a complete recovery. And in the modern era, we don't allow it to happen on its own. We give very high dose corticosteroids, really big doses, to quell that inflammation, to hasten the recovery, and to minimize the damage to the brain and spinal cord.
Dr. Boster, can you please tell me about MRI and the benefits of MRI versus not taking this, and how often one should have an MRI?
The MRI machine has revolutionized how we diagnose MS and how we manage MS. Utilizing the MRI allows us to hasten the diagnosis. And some studies show that we can speed up the diagnosis ×3 as compared to the older criteria before we adopted MRI. I want to focus for a second, though, on the importance of using the MRI after the diagnosis has been made, specifically in monitoring the success of a disease-modifying therapy. When you take a disease-modifying therapy, the intention is to prevent new attacks and to prevent new spots on the brain or the spinal cord. And the attacks manifest clinically. You don't need an MRI for that. But people can have new spots on the brain or spinal cord and not know it. And the only way to figure that out is to obtain an MRI. So if I have a patient with MS who's on a disease-modifying therapy, I think it is imperative, it's critically important that they have an MRI about once a year. And if they say, but doc, I feel great, say, I know you feel great, and I'm glad that you feel great, but I need to make sure that nothing shows up on the MRI that tells us a different story. Because if we see new spots on the MRI, despite feeling and looking good, we know that that disease-modifying therapy isn't working the way that we want. And that might prompt us to escalate the therapy or to make some other kind of change. In short, we use the MRI very heavily. It aids in our diagnosis, and it aids in our ability to assess and monitor the disease-modifying therapies. It's a critical tool in multiple sclerosis.
Okay, terrific. That was a great video that Dr. Boster gave us a lot of information there. We've got a lot of people on the line. I've got a lot of questions coming in, but I want you all to know that now is your time to type in your questions for Dr. Boster. Hopefully you will see the question box in the top right-hand side of your screen. There should be a little orange arrow, and that's the place that you need to type in your questions. In the question box, okay? And if you don't see that, try clicking on the little orange arrow, and that should open up the box and make it available to you. So I'd like to introduce Dr. Boster to you. He is a board-certified clinical neuroimmunologist specializing in MS over at OhioHealth. And we are very blessed and lucky to have him with us tonight. Dr. Boster, are you on the line?
Yes, ma'am, I certainly am. How is everyone this evening?
Oh, we're all great. Thank you for being here with us. We're really happy to have you join us.
Well, thank you for having me, and thanks for watching my video, everyone.
Absolutely. You've got a lot of fans out there. So got a lot of questions. I'm going to try to get to as many as possible. Let me get started here. This is a great question. How much importance do you put on the Tesla number of the MRI machine?
Got it. So this is a great question having to do with the MRI, the most useful neurodiagnostic in MS. It's useful both to make the diagnosis of MS and, once you have the diagnosis, to monitor response to disease-modifying therapies to see if they're working. Now, they make a reference to Tesla, which is the unit of measurement for the strength of the magnet. See, MRI stands for magnetization resonance imaging. So it uses a really, really large magnet to take the picture, believe it or not. There's no radiation, there's no x-rays. It's done with a magnet. And the Tesla is a reference to the strength of the magnet. So there are a plethora of different Tesla strengths. And I do all of my MRI imaging on a 3 Tesla scanner, which is considered sort of like a high field scanner. And the reason I do that is it gives me the most information, the clearest detail, and it allows me to see things that are harder to see when you use a lower strength magnet. Now, there are also commonly 1.5 Tesla scanners out there, and a properly protocoled 1.5 scanner isn't horrible. It's not my preference, but you can get really good pictures if they're done properly. There was an interesting study done that compared side by side 3 Tesla against 1.5 Tesla, and it demonstrated that there were lesions that you wouldn't see on the 1.5 that could be seen on the 3, hence my strong preference. Now, in the modern era, 2018, there are still arcane scanners out there, 1 Tesla scanners, so 1.0 Tesla scanners, and even these so-called open MRIs that provide 0.7 Tesla. Now, I would prefer that my patients save their hard-earned money as opposed to spending the money on those scanners, because for the question of MS, it's really inadequate. As the scanner strength, as the magnet goes down in strength from 3 to 1.5, down to 1, down to 0.7, you lose the ability to see stuff. And so even though the idea of a open MRI is terribly attractive to those of us that are claustrophobic, myself included, we can't use them because they're typically 0.7 Tesla strength magnets, and the image resolution just is inadequate. Excellent question. Thank you.
Okay, great. So it would be quite reasonable then for someone who was told to go get an MRI to call the center first and ask, what strength is your MRI or what Tesla level do you use before they make the decision as to where they get their MRI?
Yeah, really, that's a decision that you should leave to the neurologist who's ordering the scan. Okay. When I order the scan, I'm specifying with great clarity what it is I need. And I wouldn't think that it would be fair to leave that up to my patient to fight through that. So what I would recommend is, and what would be reasonable in my mind, is just to ask your neurologist, hey, when you send me for an MRI, do you care if it's on a 1.5 or a 3 or a 0.7? And then they'll tell you what they think. If you're called by an insurance company, because sometimes they do this, and they say, hey, you can get a cheaper scan down the street.
Right.
What they don't tell you is that cheaper scan is on a less strong magnet, and it's not necessarily as good of a picture. And so what I recommend patients do in that situation is you tell the insurance company just to leave it alone and to hold on, and then you call your doctor's office to clarify with your doctor what they recommend.
That's great. Thank you. Thank you for that. And staying on this topic, we have a few questions that line up together. So people are asking about maybe there's a new guideline or there's something about contrast that is new in terms of recommendations. People would like to know more about what that's all about and how you feel about having an MRI with or without the contrast because of these new guidelines or recommendations.
Absolutely. So this is a very hot topic, and I first want to explain why we even use contrast. So when you take an MRI, you can see a lot of information without the contrast. But there's certain pieces of information that are not obtainable unless you give the contrast dye. Specifically, it clues you in on new lesions, new MRI spots. So when I say new, I mean like today or within the last couple weeks, because lesions only enhance for a certain period of time. Now, when you're making the MS diagnosis, if you see these so-called enhancing lesions, which you can only see when you give the contrast, that can actually make the diagnosis. And so to do a scan without it is to profoundly limit the kind of information that you need. Similarly, when you are getting, let's say, annual screening MRIs or annual MRIs in someone who's on a disease-modifying therapy, you get a scan to see if there's any new spots. If you don't give contrast, you can learn a lot of information, a tremendous amount of information, but you can't learn everything that you really want to know. Again, if you see a new enhancing lesion, it's crystal clear that this is brand new. Whereas if you don't give the contrast and see a new white spot, you really don't exactly know the timing of that lesion. So the rationale for giving contrast in the field of MS is very solid. And it is my strong preference to give contrast, all things being equal. Now, let's talk about the risks of contrast in two different segments. First, the kidney, and then second, the sequestration or brain deposition. So as it relates to the kidney, there are concerns in situations where people have known kidney damage. So a good example would be someone who has had bad diabetes and their kidneys have been beat up from the diabetes and they don't work as well. Well, the contrast dye is processed by the kidneys. This is a very easy risk to mitigate simply by knowing the patient's kidney function. Where I work at OhioHealth here in Columbus, Ohio, we check kidney function with a very quick blood test called a creatinine before we infuse the patient. And if we don't have, so the technologists will look in the chart, and if they see a creatinine which is acceptable, all is well. But if they don't, they'll end up drawing one quickly, and that way we assure ourselves that we're not placing someone at risk of renal damage. Now, there's also been a lot of recent press, including some concerns by the actor, martial artist Chuck Norris, believe it or not, about the concerns for deposition of GAD, the contrast agent, staying in the brain, so being deposited in the brain. And that's an unsettling idea, to think that you have this stuff stuck in you. And the skinny is this. There's several different kinds of gadolinium agents. There's different kinds of colas, like you can have Coca-Cola and Pepsi-Cola. They're different kinds or brands. Well, it's the same thing with the contrast dyes. So as it relates to gadolinium agents, there's linear molecules, so linear gadolinium contrast agents, and those are the ones that have been associated with deposition in the brain. Linear is bad. Now, there's another flavor or another brand available, and these are macrocyclic molecules. So macrocyclic GAD molecules do not cause brain deposition or sequestration. They don't do that. So macrocyclic are good. And as long as we're using macrocyclic molecules, and for example, at my hospital system, we only use macrocyclic molecules, we really have zero concerns about the contrast being deposited and sequestered over time. Now, at the risk of giving you a selfless plug, I recently put out a YouTube video on my channel on this topic. So if you happen to go over to my YouTube channel, you can find a video that covers this again, just in case you want to hear it from a slightly different angle.
Okay, that's great. And I can include that in our follow-up email, that link to your YouTube video. That would be helpful.
Awesome.
A lot of questions on this. Actually, someone is also asking why they can't, knowing this, would a CT scan be better versus an MRI?
Yeah, so the question of would a CT scan be better than an MRI, the answer is a resounding absolutely not, no. The technology of the CT technology, coherence tomography, is using essentially a series of X-rays. Like imagine getting an X-ray through the body and then going up a little bit, getting another one, and then layering them on top of each other like layering a cake. And you can create a three-dimensional sort of X-ray of the person. And CT scans work great at, for example, taking pictures of the body. But when you're trying to take pictures of the brain, the CT scan is profoundly lacking. And in specific, it really does a bad job of picking up new MS lesions. The time that we use a CT scan frequently in the setting of neurology is when we're worried about an acute stroke or a bleed, because a CT scan can be obtained in under 5 minutes, and it can answer the question, bleed, no bleed, and it can do it very quickly. But when you're looking at the very, very fine detail required to help look at an MS patient's brain, that's inadequate, and so you would not want to do that.
Okay, great. Well, thank you for clarifying that. And
Absolutely.
Yeah, I'm going to shift gears a little. We've got a lot of MRI questions tonight coming in. But I wanted to, someone was asking, you mentioned during your video that you recommend to have an MRI annually of the brain. The question is, do you also recommend the spine to be included in that annually?
No, I do not, and let me address that. It's a great question. So the Consortium of MS Centers, of which we are a member, recommends an annual brain MRI as surveillance, but it does not recommend an MRI of the spine every year. I certainly think it's a best practice to obtain spine imaging, cervical and thoracic, at the time of diagnosis. The recommendation from the consortium is to repeat spine imaging if there are new symptoms attributable to the spine. And so the neurologist sorts that out by taking a history and doing a physical. Now, in clinical practice, I do obtain spine imaging, but I don't typically do it every year. I may do it every few years. So every 2 to 3 to 4 years, I'll get a spine. Now, the reason is actually based in science. It's not just like a hating on the spine. When you're getting a routine annual MRI, what you're looking for are new lesions, new brain spots that didn't present with symptoms. So you're looking for a new white spot, even though the person didn't manifest an attack. The real estate in the brain, the tissue in the brain is such, you can have lots of new spots and the human being does not experience any symptoms. And if you didn't get the MRI, you completely miss it. In counterpoint, the spinal cord is about as thick as my finger. It's a real thin structure. It's a real long, thin structure. It's like a giant wire. And damage to the spinal cord almost never goes unnoticed. So the likelihood that you would obtain an MRI of the spinal cord and see a surprise lesion, one that you weren't expecting, is very, very low. Whereas the likelihood that you see a surprise lesion on the brain MRI is much, much higher.
That makes sense. All right, thank you. Thank you for answering that question.
No problem.
During your video, you also you talked about progressive MS. Someone is asking, do you recommend continuing medication once diagnosed with progressive MS?
No, the answer to this question is a resounding absolutely, heck yes. It's a big yeah. And the reason is twofold. So the most common form of MS is relapsing multiple sclerosis. And early on in the disease process, it's primarily characterized by clinical attacks. Later on in the disease process, there's much less likelihood of having attacks, but you're still at risk of having them. So if you are in a progressive disease state and you have now what some people refer to as secondary progressive MS, it's still a relapsing form of MS and you're still at risk of having attacks. There was an interesting paper that was just published this week. The first author was Asheron, I think. And in this paper, they looked at like 1,600 people with MS who had suffered attacks. And they looked at what percentage had severe attacks, where they got at least 2 points worse on the disability scale. And that's really bad. And of the 1,600 people where they had attacks, 17% had severe attacks. Then they asked the question, a year later, how much did they improve? What they found was really, really bothersome, that half of the people, so 48% of the people that had suffered a severe attack, only recovered halfway. So they only recovered 1 point on the disability scale, not all the way back to 2. And 20% of the population, so 1/5 of the population, didn't recover at all. My point here is you don't know if you're going to have an attack, and you don't know if it's going to be severe. And so the idea of stopping the medicine, knowing full and well that you're still at risk, to me doesn't make any sense at all. Second of all, when you look at progressive MS, these medicines work. And they may not work in the most traditional of senses, but we have to look into the data. And I'm going to give you an example. There's a medicine out there which is considered to be a really great medicine called natalizumab, or codename Tysabri. And it's approved for relapsing forms of MS, and it really halts relapses like a really good job. And a couple years ago, the manufacturer wanted to do a big study called the Ascend trial. And the Ascend trial looked at secondary progressive MS. And we ran this big trial, and the conclusion was, it didn't work. Because giving natalizumab, Tysabri, didn't slow down the progression disability scale. So that's a bummer. But when you look at the data, the post hoc data, what they discovered was it maintained hand function. Now, when you have progressive disease, typically the legs are beat up worse than the arms, or the legs get beat up first and the arms later. And there's a theory that there's more tissue left to preserve in the spinal cord and brain subserving the arms. And so given that we now know that certain drugs can maintain function, even in a progressive patient, and we've seen this now in other drugs as well. For example, in ocrelizumab. When you look at the ocrelizumab data set, not only does it slow down PPMS in general, but it seems to maintain hand function. So I would never want to stop that opportunity for someone. I want to keep that going.
Okay, that's great. You're sparking a lot of questions now. So even if you're 69 years old, the question is, do I still take a disease-modifying therapy?
Well, I guess I would turn the question around and say, do you have any neurological functions that you want to keep? So, for example, if you're 69 and your legs work, you might want to maintain leg function. If you're 69 and your arms work, or let's say only one of your arms work, you might want to maintain arm function in the one that works. If you're 69 and you have two eyeballs and they work, you might want to keep them. Or if you can think clearly and read a book and comprehend it and carry on a conversation with your spouse, you might want to maintain that. You might want to maintain swallowing function or bowel function or bladder function. So my point is, if there's neurological reserve left, I want to preserve it. And I don't care if you're 69 or 79. I think that we have to look at what is at risk to lose, and then what's the risk-benefit of the medicine.
Yes, she wrote, thank you. Thank you very much for that answer.
My pleasure.
So, unfortunately, we're going to go in the direction of wrapping it up, but it's wonderful because as you keep answering questions, you're sparking more conversation here.
Well, let's just do one more just for fun.
Okay, so one more just for fun. So in your experience over at OhioHealth MS Center, you're seeing so many people. What do you recommend to recover from attacks? Types of therapies, types of medications, alternative therapies. What do you see people best respond to recover?
So that's a great question. So let's take as a foregone conclusion that we're dealing with a real, like a clinical attack where there's acute inflammation in the brain or spinal cord that's causing a focal neurological deficit that's lasting longer than a couple days, and it's occurring in the absence of a fever. All right, so this is the classic relapse definition. We're not talking about a pseudo-relapse where someone has a urinary tract infection causing worsening symptoms or anything like that. Okay, so then what do we recommend to hasten relapse recovery? So the first mainstay is steroids. Is to give high-dose corticosteroids, whether that be high-dose oral, which is my preference, high-dose IV. If we do the IV, we can do it at home. We can do it in the infusion center. There's a lot of different ways to do that. If they can't take steroids, or if the steroids are given and don't work, then we move to second-line therapies. And second-line therapies can include another medication called Acthar. Acthar is a hormone that makes your body make its own steroids. Mm-hmm. Or we use something called total plasma exchange, which is kind of like an oil filter for the blood, where they filter the blood out and put it back. And that can be, both of those can be successful when steroids have not been successful. And so very clearly there's an entire medical arm to try to how we treat this. Now, there's one study out there that was fascinating looking at optic neuritis specifically. And it looked like if you gave people steroids with a old anti-seizure medicine called Dilantin, they seemed to preserve more function than if they only got steroids without Dilantin, which is really fascinating and makes you think about like potentially neuroprotection and a lot of other exciting ideas. I don't think that's prime time yet. I don't think that we can go out and do that until that's been replicated. That's just my opinion. Now, there's a lot of other things that we can do symptomatically to improve quality of life and to get the person functionally better. And that really depends on what's wrong. For example, if someone has an attack which causes them to be imbalanced, the steroids are one piece of the puzzle, but physical therapy to rehabilitate their balance is the other piece of the puzzle. And so we're not just going to give someone steroids and say, have a nice day. We're going to try to address the underlying problem and the functional problem at the same time. Now, the key message, so if you didn't listen to anything I just said, just please listen to this part. The key message is, whatever you're doing, you need to follow up in 4 to 6 weeks to make sure that human being is improving. What hurts my feelings is when a doctor says, okay, well, here are your steroids, I'll see you in 6 months. Because that doctor doesn't know if that human being is recovering or not. And so I think as a best practice, we have to have a follow-up visit in the neurologist's office 4 to 6 weeks after the initiation of, say, steroids to ensure proper recovery. Okay,
thank you. And
no problem.
Thank you for joining us tonight. This has been incredibly informative, and we have a lot of appreciative people on the line, and they're asking for us to send them the link. We will be sending a recording of this out to everyone, so don't worry.
Oh, wonderful. That's awesome.
Yeah, and thanks for being on the line with us, Dr. Boster. We really appreciate it.
Oh, it's my pleasure. Take care, everyone. Be safe and have a great night. Bye-bye.
You too. Bye-bye. And thank you all for joining us tonight. For more information, please visit us at www.msvn.org. You are welcome to follow us on our YouTube learning channel, the MS News YouTube learning channel, and you will find this recording there. We will be sending this out to all of you, and we hope that you join us again next month. Thank you again, and good night.